Welcome to Pharmaconhealth, your gateway to mastering pharmacology with science, simplicity, and clarity. You have prescribed two medications that both help your patient, but together, one makes the other dangerously toxic. This scenario plays out in hospitals and clinics every day. Drug interactions are one of the leading causes of preventable patient harm worldwide. In this video, we will break down exactly how and why drug interactions happen and what clinicians and pharmacists can do to prevent them. By the end of this video, you will clearly understand the two major categories of drug interactions, pharmacokinetic and pharmacodynamic, the specific mechanisms within each category, clinically critical real-world examples including CYP450 interactions, protein-binding displacement, additive CNS depression, and serotonin syndrome, and the evidence-based strategies used to identify, prevent, and manage interactions in practice. Let us begin with the foundation, what drug interactions are and why they matter so much clinically. A drug interaction occurs when the presence of one drug, food, or substance alters the pharmacological effect of another drug. This alteration can move the effect in either direction. A drug that was previously at a safe therapeutic concentration can be pushed above the toxic threshold or pulled below the minimum effective concentration. Drug interactions can involve two prescription drugs, a drug and an over-the-counter medicine, a drug and a herbal supplement, or a drug and food. All of these combinations are clinically relevant. Drug interactions are clinically important for three major reasons. First, they are common. Polypharmacy, the use of 5 or more medications at the same time, is widespread, especially among elderly patients. As more drugs are added to a treatment regimen, the probability of a clinically significant interaction increases sharply. Second, drug interactions cause real harm. They are responsible for approximately 20 to 30% of all adverse drug reactions and contribute significantly to hospital admissions worldwide. Third, most drug interactions are preventable. With proper knowledge and systematic medication review, the majority of harmful interactions can be identified and avoided before they ever reach the patient. Drug interactions are divided into two fundamental categories, pharmacokinetic interactions and pharmacodynamic interactions. Let us examine each category in depth, beginning with pharmacokinetic interactions. Pharmacokinetic drug interactions occur when one drug alters the absorption, distribution, metabolism, or excretion of another drug, changing its plasma concentration without directly acting on the same receptor. The key point is this: the interacting drug does not itself produce the altered effect. Instead, it changes how much of the target drug becomes available in the body. If more drug is present in the body than expected, the effects become stronger than intended and may potentially become toxic. If less drug is present than expected, subtherapeutic levels may occur, leading to treatment failure. Absorption interactions occur before a drug even reaches the bloodstream. Three major mechanisms are involved. First, pH changes. Antacids raise gastric pH, impairing the absorption of drugs that require an acidic environment for dissolution, such as itraconazole and ketoconazole. Second, chelation. Tetracycline and fluoroquinolone antibiotics bind tightly to divalent metal ions such as calcium, iron, and magnesium, forming insoluble complexes that cannot be absorbed. For this reason, these antibiotics should not be co-administered with dairy products, antacids, or iron supplements. Third, altered gastrointestinal motility. Metoclopramide accelerates gastric emptying, reducing the absorption time of some drugs, whereas opioids slow gastrointestinal motility, prolonging drug residence time and increasing the absorption of others. Distribution interactions primarily involve competition for plasma protein binding sites. Many drugs circulate through the bloodstream bound to plasma proteins, especially albumin. However, only the unbound, or free, fraction of a drug is pharmacologically active. When two highly protein-bound drugs are administered together, they compete for the same binding sites. As a result, one drug may displace the other from the protein. The displaced drug then becomes free in the circulation, producing a much higher active concentration than intended. A classic example is the interaction between warfarin and aspirin. Both drugs are highly bound to albumin. Aspirin can displace warfarin from its binding sites, increasing the free concentration of warfarin and enhancing its anticoagulant effect, which significantly raises the risk of serious bleeding. Metabolism interactions are the most clinically significant category of pharmacokinetic interactions and are responsible for the majority of serious drug interaction events. Most drug metabolism occurs in the liver through the cytochrome P450 enzyme system, particularly the enzymes CYP3A4, CYP2D6, CYP2C9, and CYP2C19. These interactions occur through two opposite mechanisms: enzyme induction and enzyme inhibition. Enzyme induction occurs when one drug increases the gene expression of a cytochrome P450 enzyme, leading to greater enzyme production and accelerated metabolism of co-administered drugs. As metabolism increases, plasma drug concentrations fall, potentially reducing therapeutic effectiveness. Enzyme inhibition occurs when one drug blocks the activity of a cytochrome P450 enzyme, slowing the metabolism of co-administered drugs. This causes plasma drug concentrations to rise, potentially reaching toxic levels. Key cytochrome P450 enzymes involved in metabolism interactions include CYP3A4, CYP2D6, CYP2C9, CYP2C19. Plasma drug level is inversely proportional to the rate of metabolism. Two landmark clinical examples illustrate CYP450 interactions. First, rifampicin and oral contraceptives. Rifampicin is a powerful inducer of CYP3A4. It dramatically upregulates the enzyme, accelerating the metabolism of ethinyl estradiol in combined oral contraceptives. This reduces contraceptive plasma levels to subtherapeutic concentrations, causing contraceptive failure. Patients must use additional barrier methods and be clearly counseled about this interaction. Second, grapefruit juice and statins. Grapefruit contains furanocoumarins that irreversibly inhibit intestinal CYP3A4. This blocks the first-pass metabolism of statins such as simvastatin and atorvastatin, dramatically increasing their bioavailability. Elevated statin levels significantly increase the risk of rhabdomyolysis, severe muscle breakdown that can cause acute kidney failure. Excretion interactions occur primarily at the kidney. Two main mechanisms are involved. First, competition for renal tubular transporters. Probenecid inhibits the organic anion transporters in the renal tubule that secrete penicillin into urine. This reduces penicillin clearance, prolonging its plasma half-life and increasing its antibacterial effect, a deliberately exploited interaction used historically to conserve penicillin. Second, urinary pH changes. The degree of ionization of a drug in urine determines how much is reabsorbed versus excreted. Alkalinizing the urine with sodium bicarbonate traps acidic drugs like salicylate in ionized form in the urine, accelerating their elimination, a clinical strategy used in salicylate overdose management. Now let us move to the second major category, pharmacodynamic interactions, where drugs affect each other not through their concentrations, but through shared biological targets. Pharmacodynamic interactions occur when two drugs act on the same receptor, pathway, or physiological system, producing an effect that is either greater or lesser than either drug alone. Unlike pharmacokinetic interactions, drug plasma concentrations may remain completely unchanged. The interaction happens entirely at the pharmacological target level. There are three outcome types: additive, where the combined effect equals the sum of each drug's individual effect; synergistic, where the combined effect exceeds the sum; and antagonistic, where one drug reduces or blocks the effect of the other. Additive and synergistic interactions can be either intentional, designed to improve therapy, or dangerous. Intentional synergy. Co-trimoxazole combines trimethoprim and sulfamethoxazole, both of which inhibit folate synthesis in bacteria, but at sequential steps. Their combined bactericidal effect far exceeds either alone. Another intentional example, combining an opioid and a nonsteroidal anti-inflammatory drug for post-operative pain achieves additive analgesia while using lower doses of each, reducing opioid-associated side effects. The dangerous side, combining two CNS depressants, for example, a benzodiazepine with an opioid, produces synergistic respiratory depression. Together, they suppress breathing to a far greater degree than either drug alone, and this combination is responsible for a significant proportion of opioid overdose deaths. Antagonistic interactions occur when one drug blocks or reduces the effect of another at the receptor level. Competitive antagonism can be reversed by increasing the agonist dose, whereas non-competitive antagonism cannot be overcome in this way. Two clinically critical examples of life-saving antagonism. Naloxone is a mu-opioid receptor competitive antagonist. It rapidly reverses opioid overdose by displacing the opioid from the receptor. It must be administered before respiratory arrest becomes irreversible. Flumazenil competitively antagonizes benzodiazepines at the GABA-A receptor, reversing benzodiazepine-induced sedation and respiratory depression. Both are antidotes that exploit pharmacodynamic antagonism therapeutically. Now let us examine the most clinically significant real-world drug interaction scenarios that every prescriber must know and how to manage them. Certain drugs carry inherently higher interaction risk because any change in their plasma concentration, up or down, produces serious clinical consequences. The highest risk category is narrow therapeutic index drugs, which we covered in detail in Episode 1. Warfarin interacts with dozens of drugs through CYP2C9 inhibition, CYP2C9 induction, protein binding displacement, and vitamin K pathway effects, making it one of the most interaction-prone drugs in clinical use. Digoxin is affected by P-glycoprotein transporters, and drugs like amiodarone and clarithromycin raise digoxin levels by inhibiting PGP, causing life-threatening arrhythmias. Lithium levels are dramatically increased by NSAIDs and thiazide diuretics, which reduce renal clearance, turning a therapeutic dose into a toxic one. One pharmacodynamic drug interaction deserves special attention because it can be fatal and is frequently missed: serotonin syndrome. Serotonin syndrome occurs when two or more serotonergic drugs are combined, producing excess serotonin activity in the central and peripheral nervous system. The classic triad is altered mental status, autonomic instability, and neuromuscular abnormalities, specifically clonus, which is the rhythmic involuntary muscle jerking that distinguishes serotonin syndrome from other drug toxicities. The most dangerous combinations involve monoamine oxidase inhibitors, which prevent serotonin breakdown, combined with SSRIs, SNRIs, tramadol, linezolid, or methylene blue. Monoamine oxidase inhibitors combined with serotonergic drugs such as sertraline or tramadol can precipitate serotonin syndrome. Serotonin syndrome can progress from mild agitation to multi-organ failure and death within hours. Recognition and immediate drug discontinuation are life-saving. A third high-risk example is the combination of statins and fibrates. Both drug classes independently carry a risk of myopathy, muscle damage. When combined, particularly simvastatin or levastatin with gemfibrozil, the interaction becomes both pharmacokinetic and pharmacodynamic. Gemfibrozil inhibits CYP2C8 and glucuronidation, key metabolic pathways for statin clearance, leading to significantly increased statin plasma concentrations. Simultaneously, both drugs independently impair mitochondrial function in skeletal muscle. The result is a dramatically elevated risk of rhabdomyolysis, widespread muscle breakdown releasing myoglobin into the bloodstream, which can precipitate in renal tubules and cause acute kidney injury. Monitoring creatine kinase levels and avoiding the gemfibrozil statin combination where possible is essential. Understanding the mechanisms is only the first step. The clinical goal is prevention and management. Let us examine the systematic approach. Understanding the Makani-preventing drug interactions requires a four-pillar approach. First, medication reconciliation. A complete, verified list of all drugs the patient is taking must be obtained at every clinical encounter, including prescription drugs, over-the-counter medicines, herbal supplements, and vitamins. Incomplete medication histories are the single most common root cause of missed interactions. Second, systematic interaction screening. Electronic prescribing systems with integrated drug interaction alerts and reference databases such as Micromedics, Lexicomp, and Stockley's drug interactions should be used proactively. Third, dose adjustment. When a known interaction cannot be avoided, Adjust the dose based on the expected magnitude of the interaction and monitor accordingly. Fourth, timing strategies. Some interactions can be mitigated by separating drug administration times, such as giving tetracycline at least 2 hours before or after calcium-containing products. SMS is only the first step. The clinical goal is prevention and management. Let us examine the systematic approach. Certain patient populations require heightened vigilance for drug interactions. Elderly patients on polypharmacy are the highest risk group. Reduced hepatic enzyme activity and declining renal function mean that both pharmacokinetic and pharmacodynamic interactions are more pronounced and longer-lasting. Patients with hepatic impairment have reduced cytochrome P450 metabolism capacity, making inhibitory interactions more dangerous. Patients with renal impairment have reduced clearance of drugs and active metabolites, amplifying excretion interactions. Patients on antiretroviral therapy for HIV carry some of the most complex interaction profiles in medicine. Protease inhibitors and non-nucleoside reverse transcriptase inhibitors are powerful CYP3A4 inhibitors and inducers simultaneously. HIV infection treatment regimens can therefore produce extensive drug interaction networks. And pregnant patients require special caution because interactions may affect fetal drug exposure. Patient education is an indispensable layer of interaction prevention that no electronic alert system can replace. Patients must be instructed to always disclose all medications, prescription, over-the-counter, herbal, and recreational, to every healthcare provider. They must understand specific food, drug interactions, grapefruit juice and statins, leafy greens and warfarin, tyramine-rich foods, aged cheese, cured meats, and monoamine oxidase inhibitors. They must be taught to recognize early warning signs of common interaction toxicities, unusual bleeding for warfarin, muscle pain for statins, excessive sedation for CNS depressants. And they must be given clear guidance on administration timing when separation of doses is required. Let us close with a comprehensive clinical summary, the essential facts every pharmacist and clinician must carry into practice. Here is your definitive clinical summary. Drug interactions occur when one drug, food, or substance alters the pharmacological effect of another, either pushing drug levels toward toxicity or lowering them below the therapeutic threshold. Pharmacokinetic interactions act through ADME mechanisms. Absorption interactions via pH change, chelation, or motility alteration. Distribution interactions via protein binding displacement. Metabolism interactions via CYP450 induction or inhibition, the most clinically significant category, and excretion interactions via renal transporter competition or urinary pH changes. Pharmacodynamic interactions act at the receptor or physiological level. Additive effects, synergistic effects, which can be therapeutic or dangerous, and antagonistic effects, which underpin life-saving antidotes like naloxone and flumazenil. The highest risk scenarios in clinical practice include warfarin interactions, digoxin and P-glycoprotein inhibitors, lithium with NSAIDs or diuretics, serotonin syndrome from serotonergic combinations, and rhabdomyolysis from statin-fibrate combinations. Prevention requires complete medication reconciliation, systematic interaction screening, dose adjustment, timing strategies, and consistent patient education. If this video strengthened your understanding of drug interactions and how to prevent patient harm, please subscribe to Pharmaconhealth and share it with your colleagues and clinical teams. Thank you for learning with Pharmaconhealth, where pharmacology protects lives.